Our next presenter, Dr. Carlo De Angelis, is the Oncology Pharmacy Clinician Scientist at the Center and previously clinical practice lead for the Oncology Pharmacy at Sunnybrook Cancer Centre. His area of research interests include the prevention and management of cancer treatment-related side effects, particularly in the elderly, and the role of pharmacists in improving outcomes of targeted anti-cancer therapies. He has been working on developing a research program to evaluate the use of plant-derived cannabinoids for symptom management in the oncology setting. And over 3 years ago, not including the years he spent pushing for the development of this program, Dr. Carlo De Angelis created the Cannabis Consultation Service at Sunnybrook Odette Cancer Centre to meet the needs of cancer patients interested in using plant-derived cannabinoids for medical purposes. This is the first such service dedicated to cancer patients' use of plant-based cannabis in Canada, and today we are very lucky to have Dr. De Angelis speak to us on his pharmacist-led consultation service at the Odette Cancer Centre. Welcome.
Thank you, Carolina, and thank you for inviting me to speak today. It has been actually quite a journey, hasn't it? In terms of us working together. I think the other thing, just reflecting on some of the presentations this morning, I have to say that I feel vindicated, maybe validated. It's been a real challenge with this program that we've put in place at Sunnybrook. And it actually, I think, has addressed a lot of the issues that came up in the Health Canada recommendations and some of the discussions that we've had this morning. So I'll move forward. Okay. So I have no conflicts of interest, and that includes, despite the fact that we use Avicanna products exclusively, we do not get funding to run the program or research to date. Two objectives, really, and that's hopefully at the end of this presentation, you'll understand the unmet needs of cancer patients wishing to use cannabis, plant-derived cannabis for medical purposes, and the role of the pharmacist in terms of that the pharmacist may play in this setting. So I'm going to talk a little bit about research that is out there from other researchers and some of our research, but this is from BC, and they surveyed cancer survivors across the country. 33 patients interviewed, more than surveyed, but interviewed, and looking at their three components of their beliefs in terms of the use of cannabis or the desire not to use cannabis or why they would not use cannabis. So you'll see in the next few slides, I'm dividing it up into sort of just common findings from these interviews with patients. These are cancer patients, and then the users and non-users of cannabis in terms of their beliefs. And then in terms of this first slide in terms of behavioral beliefs, all patients felt, whether they were users or non-users, felt that cannabis, in fact, plant-derived cannabis, could help cancer and cancer treatment-related symptoms. So I think that's a really important finding, that there's a strong belief out there in terms of the potential for cannabis. The users of cannabis basically were using it for a number of reasons. One is they wanted to reduce polypharmacy, and we know that that's very common in our field, particularly, and especially when it comes to symptom management. You know, a patient can go from, let's say, if they're an elderly patient on medication for hypertension, cholesterol, diabetes, they might be on 4 or 5 medications, and then we start their anti-cancer treatments, and we right away add 5 or 6 more medications for symptom management. So now you've gone from 5 medications to 10 medications within days. So, you know, polypharmacy is a real issue. So I can understand why perhaps the desire to see how cannabis might help across symptoms. And again, it is validated by that belief that it could perhaps replace prescribed medications. Non-users, you know, we're concerned about drug interactions, and we deal with that as part of our service, and it was mentioned earlier by Samantha in terms of MyMedi. They do a medication history and evaluate the potential for drug interactions. And they felt that the patients are non-users, they felt that their symptoms were adequately being managed. But that's not everybody, right? In terms of beliefs, in terms of normative beliefs, sort of what drives the use or non-use of cannabis, all patients, whether they were users or non-users, you know, had a variety of individuals in their lives who they value the opinion of. And I think this just speaks to how important the opinion of not just healthcare professionals, because that's mentioned here as well, but also the importance of the people around them, their family members, friends, in terms of their perspectives on the use of cannabis. And clearly the patients that are using cannabis have that family support. I think one of the other findings in terms of this disapproval led to communication challenges, and that speaks to basically the patient bringing it up to the clinician and the clinician shutting all doors. And we've certainly heard that and seen that even at the Cancer Centre, even despite our 3 years of working with our patients. And then finally, in terms of in this study, there are outside factors that determine the behavior of patients. Certainly legalization seems to have made it a little bit easier in terms of accessing cannabis. And it's interesting that there's this perception that there's no need to worry about the quality of cannabis, and I would argue against that. So I think it speaks to the need for education of patients wanting to use cannabis. Interestingly, non-users were worried about dependency, and again, I think a room for education here in terms of use of cannabis. So, this is an editorial that was published actually 6 years ago now. It's hard to believe. But basically, if cannabis is ineffective, and that's the stance of many healthcare professionals, and generates all these side effects, then why are 3.4 million Canadians using it? And basically, patients are telling us they continue to use cannabis because it's helping them. And I think at the end of the day, I think one of the things in terms of the editorial basically saying it's in our interest, whether it be family physicians. This was an editorial focused towards family physicians, but I would say any healthcare professional. I put in pharmacists there. But basically, we need to familiarize ourselves with cannabinoids and how they're used so that we can help our patients when they come to us wanting to use plant-derived cannabis for various symptoms. When we've talked a lot about evidence today, right? And the fact that we're real-world evidence. And, we as healthcare professionals value those top three of that pyramid, right? The evidence, the systematic reviews, randomized controlled trials, which has been mentioned a lot today, and non-randomized controlled trials, perhaps a lot less. But the reality is, patients, they don't care. They value all the evidence in that pyramid. And I think we need to start thinking about, what does evidence really mean, right? And what evidence is available to us, and what can we do with that evidence to actually support patients wanting to use cannabis. So this has also been discussed. I think a couple of people have talked about this, and one of the issues that we found, and I'll talk a little bit about, I think in the next slide, talking a little bit about the setting up of the program. This was data out of the US, Minnesota, which has a medical cannabis program. And they surveyed over 1,100 patients using cannabis for various reasons. But there's a number of findings in the study, but I thought this was really important in terms of why we decided to implement a program at the Cancer Centre. So first of all, in terms of the types of products that people are using, it's often 40% of patients are using only one ratio. So there's which means 45% or maybe even 15%, 60% are using different ratios of THC to CBD. But if you look at that 40% using a fixed ratio, so not varying their product selection over time, and this was a year of use, 29% are using high THC products, 10% are balanced, and only 1% are high CBD. When you look at patients who are using multiple ratios, 42% are using high THC and a balanced THC. So, and I won't go through all the data, but basically patients are, even in a controlled program, such as in Minnesota, are using a lot of high ratio THC products. And I'll show you we don't use those types of products, and we still have success. The routes of administration is another issue that's come up today, and 31% only use one route. Many patients, over 60%, are using more than one route, and that may be appropriate depending on the clinical situation. So 15% are using oral, 11% inhaled or vaporized. Of the 66% using multiple routes, about half of them also involve inhalation, or some are using some form of inhalation, which we don't support. So we did a survey a few years ago. Actually, it's hard to believe. The manuscript isn't finally in preparation. But we basically reviewed, so we looked at our patients receiving systemic therapy at the Cancer Centre. We screened over 7,000 patients' appointments for eligibility. And of course, we removed duplicates. We removed patients who we had approached before and had agreed to participate, as well as those that said they would not participate. We had surveys completed by 234 patients. That was our planned accrual patient population. 61% were female with a median age of 60 and a very wide range of ages, anywhere from 22 years of age to 89. So I think and this was very representative of our population. We did check that. The rate of medical cannabis use was 19%, which we sort of expected. Actually, we calculated our sample size based on what we thought the rate of use was. So basically, 1 in 5 patients are using cannabis. The more interesting result of this survey is that only 35% of those patients are actually using it in consultation with a healthcare professional. So think of that number. And 72% of patients, 18% were using it with the advice of a consultant. So 82% of patients were not under the care of a healthcare professional. They were just out there finding their own cannabis. 33% of patients said they would use cannabis. Interestingly, when we said, what if your healthcare professional recommended it, in particular your medical oncologist, that number went up to 72%. So if a physician recommended a product for symptom management, a vast majority of patients would be willing to try it. Okay, the service. So why did we develop the service? So the administration at Sunnybrook knew I was or at the Cancer Centre knew I was interested in cannabis. They came to me and said, is there a best medical cannabis clinic that we can send patients to so that we don't have patients coming to ED with a psychotic episode? And that's actually what happened. That happened twice within the month before they approached me. Our patients, cancer patients, coming to the ED, emergency department, with psychotic symptoms because of using high-dose THC products. Okay? So they came to me and said, is there a clinic that you could recommend? And so I looked into it, and the reality was, in my mind, and again, this is my personal opinion, is that there was a lot of variability in support from clinic to clinic. And there are a lot of issues that I felt was really important to our patients, besides the fact that just trying to, the fact that, these outside clinics don't really know the anti-cancer treatment that the patients are receiving, where they are along in their cancer journey, and how that cannabis might interfere or interact with the anti-cancer therapies. So I think there's a number of issues that I identified, and that, for me, led me to sort of recommend we take it back in-house. One is just navigating the system. There's a lot of variability there in terms of helping patients navigate that authorization process, product selection, et cetera. Which choice of approved grower, which choice of product, all related to navigation, what route of administration, how do I dose titrate? And again, there's a lot of variability from clinic to clinic. Some do it really, really well, others not so well, leaving the patient to their own sort of resources. And I think the importance of assessing benefit and adverse effects in a timely manner was really important to us too. So when we're titrating, we call patients 2 to 3 times a week while we're titrating. When we're assessing, as they get to a dose where they feel they're getting benefit, then we're following them maybe for the first month, we're following them once a week, and then we back off to every 3 months once they're stable and standardized. So, timely and follow-up at a time when they need particular help, whether that be dose titration, managing of side effects, et cetera, is really important. You can't just sort of manage everybody the same way with, we'll talk to you in a month's time or 3 months' time. Here's the product, go to it. And it was really important for us to have a consistent sort of message in terms of education and counseling of the patient. We also found that early on in the program and before we partnered with Avicenna, we did work with other licensed providers, and there was a lot of upselling. And that really bothered us because patients were complaining about getting calls from growers, approved growers, telling them, you might want to use this product for this or that product for this other symptom that you have. And that really bothered us. It bothered patients. They complained to us. Okay, so how does the program work? Anybody can refer a patient to the Cannabis Consultation Service, including patients themselves. We have a Sunnybrook email, which was really interesting to get, but we did get it, med.cannabis@sunnybrook.ca. The goals of the program are to provide timely and appropriate advice about regarding the use and access to plant-derived cannabis for managing symptoms and cancer treatment-related adverse effects. Our goal is to ensure safe use of cannabis, to support patients through the authorization process, product selection, dose titration, et cetera, which I've sort of already talked about. Access to assess response and occurrence of adverse effects in a timely manner. And again, provide education to patients. Those are our goals. So in terms of assessment, we determine the need for medical cannabis, and we run a battery of tests, or sort of standardized. We use standardized questionnaires. So patients are assessed based on what their desire or what they're wanting to use cannabis for. Typically, we get referrals for pain, poor appetite, cachexia, insomnia, anxiety. I would say it's uncommon for us to get nausea, vomiting requests, but we do get some. But the main ones are pain, insomnia, anxiety, and we get some cachexia as well. Again, standardized assessment tools. We look at what they've tried for that particular symptom, and if there's something that could be fine-tuned in terms of standard of care therapy. And we review the patient's medications for drug-drug interactions, and in particular, their anti-cancer treatment. And there's a number of now publications suggesting that there are some potential adverse outcomes in patients using combined cannabis and some of the anti-cancer treatments. And I think there's more work to be done there. It's not typically a showstopper for us. And we evaluate where the patient is along in their patient journey. You know, we make a very different decision about drug-drug interactions when we're talking about treating a cancer patient for curing their cancer, early disease, adjuvant treatment, et cetera, versus a patient who's in a metastatic, late-stage disease where we're just trying to control the disease process for as long as possible. And so our assessment of that drug-drug interaction takes into account, you know, where the patient is along their cancer journey and what the goals of therapy of that anti-cancer therapy is. And so we, drug interactions I've talked about, and then there's, we take a history of cannabis use if they're using it or have tried it. So in terms of authorization, we complete the authorization form for the physician, and you know, it's interesting to see Health Canada's report saying that it needs to be more information on that form. We've been doing this now for 4 years. We have to, by regulations, 3 grams or 5 grams of cannabis, you know, per day type of thing. But underneath that is the product that we're recommending, Avicana 050, 250, 520, or the gel. Those are the 4 products that we use. We specify the product as part of the prescription. We specify the dose titration. Typically, we start at bedtime and then increase to 2 to 3 times a day, depending on the indication. If it's just for insomnia, of course, then we're just dealing with using it at bedtime. So the first dose is always at bedtime to minimize any disruption in terms of side effects, and we titrate upward in increments. We assess adverse effects particularly early on during that titration period. And as I said, we call 2 to 3 times a week to begin with, back off to once a week for a few weeks, and then every month to 3 months after that. And we're also assessing for efficacy during that time. But I can't tell you how important it is for the physicians authorizing that cannabis that we actually put a product on there with concentration and dose. So we don't just say 250, we say which is equivalent to 2 milligrams of THC per mil and 50 milligrams of CBD per mil. The dose is 0.1 mil, equivalent to X milligrams of THC and CBD. The physicians know what they're authorizing. And that's really important. So I'm going to finish off with some cases, but I just want to talk a bit about evidence-based medicine. Earlier I talked about our paradigm in the healthcare is to have the highest level of evidence possible. But patients really, they're okay with, hearing from a friend of a friend, or, case reports, or they're okay with that in terms of wanting to try cannabis. But when we think about evidence-based medicine, often we think about the best evidence available, that pyramid, right? But in fact, and then there's the part of the clinician judgment, and is this the right thing for my patient? But I think what's often missed is the patient's perspective. Really, if you're really going to practice evidence-based medicine, you have to respect what the patient is looking for and what they want out of this, and educate them in terms of whether this is an appropriate choice and what that choice might be. Okay, a couple of patients, and I did not know what the speakers this morning were going to talk about, but these cases basically illustrate the challenges that we come across and really very much validate what was talked about this morning. So here's a 75-year-old gentleman who is on maintenance therapy for their cancer with severe neuropathic symptoms from their treatment. And so I don't know if any of you maybe are past cancer survivors with some neuropathy from the treatments we've delivered, or perhaps have family members. But basically, neuropathic pain from most of our chemo treatments are what's called stocking glove. So stocking glove meaning that most of the symptoms in terms of numbness, pain, etc., are in the hands, the glove part, or in the feet, typically the soles of the feet, etc. And I actually just spoke to this gentleman last week, and you'll know why in a moment. But basically, he said to me, I can't feel the bottom of my feet. So he has to look at the stairs to see that he's actually going down the stairs. So think about that, how we take that for granted. I'll walk off the stage down those steps, not even looking, because I can feel my feet are going down the steps. So think about not being able to actually sense where your feet are. So it's not just pain, okay? And what about this morning when you put on a shirt and you're buttoned? You weren't looking at your buttons, you were just doing it. These patients, they need to look at their button to make sure that they're actually holding it, putting it through that loop in its worst case scenario. And this gentleman has quite severe symptoms. We actually saw this gentleman 2 years ago. And this was the assessment 2 years ago. And the concern was that they had lowered the dose of his maintenance treatment to the point was the next dose reduction was stopping the therapy. It was 2 years ago. So we assessed his pain, assessed worst pain 7, least 10, again, standardized assessment. At that time, these were the medications he was on. He had tried cannabis on his own, one from a friend, and the topical CBD provided some great relief. Tried another topical cream. I'm not going to give you the brand names, et cetera. We collect that information. Didn't provide any relief. And then, on the advice of another friend, tried hemp oil with, again, no relief. So we recommend 050. We've had a lot of success with the 050 with neuropathic pain. We titrated it over a week to a mil twice daily. And at that time, his worst pain was 5, his least was 2, the average was 4, so we've made some impact on his pain. And he basically didn't really want to go any higher. We said, we could go higher to see if there's more relief. And he was having no side effects, by the way, just to be clear about that. But he said, I'm good with this. I'm good with it. And then after, we had called him a few months, because we call on a monthly basis after they reach a certain plateau, he basically said, you know what, stop following me. I'm good. I'm going to stay on the therapy, right? And in fact, he's continued to fill his prescriptions over 2 years. And we actually had planned to call him just this week. And then last week, we got a referral from the palliative care doctor saying, could you reassess this patient? So he was re-referred to the consultation service. Again, we had planned to talk to him this week. And these were his pain medications, so clearly there's been an escalation in terms of some of his pain medications, but he was still taking the CBD oil and felt that there was benefit that was being gained from the CBD oil. Now the clinician, the palliative care doc, thought, you know what, let's add a little bit of THC. You're taking straight CBD, it's helped you, let's add some THC, and we're going to add nabilone. Unfortunately, the nabilone caused significant sedation and mental cloudiness. He was really unhappy and basically stopped the medication on his own. On his follow-up appointment 2 weeks later with the palliative care doc, he said, I'm not taking that anymore, I'm done. So that's when the referral came to us. So I assessed him just last week, worst pain 8 out of 10, least 2 out of 10 just when sitting, and the average pain being 6 out of 10. We recommended a product of 250, and the reason that we went to THC despite the side effects with the nabilone are two. And this is the kind of thing that I think you have to think about when you're managing these patients. Essentially, nabilone is 10 times more potent than THC. And so effectively, by starting at a dose of using 250 and starting at a dose of 0.5, we're actually just giving him 0.1 milligram of THC. And we'll titrate up rapidly to see if he gets benefit. He did get benefit from the nabilone, but all those side effects, he just didn't want anything to do with it. So we'll see. We just started this last week. Okay, last patient, and then I'm done. So basically an 85-year-old metastatic cancer patient referred for insomnia. And I'm going to go through this quickly, not as much detail, but basically we assessed the patient for insomnia, and they had a number of issues with respect to sleep. But what was interesting is one of the reasons they wanted to get better sleep was because they felt it would help their pain. So we did a pain assessment. So that's part of, again, that assessment process and being able to sort of adapt to what the patient's telling you. Pain medications are listed here. Cannabis use history. So this was the reason they actually self-referred. They had gone to a licensed dispensary, and they were given a product with 30 milligrams per mil of THC and no CBD. And it helped their sleep, but they were euphoric, dysphoric, and it was just way too intense for them. They said, that literally took one dose, felt this way, I'm done, I'm not doing anything more. And so we actually went, our plan was, we recommended 250, and it's helped her sleep, although it hasn't helped her, hasn't helped her pain yet, but we're still in the titration phase. Okay, I'm running out of time, but I'm just going to finish the value of our service to patients. So this was something done by my master's student, and we're just finishing up the manuscript. Basically, we assessed 32 patients as early on in the program, 32 patients for eligibility. We fully interviewed 10 patients, and basically a number of themes came out of those interviews. They really liked the fact that we were integrated in with their care. They wanted their healthcare professional, their oncologist, medical oncologist, MC on the slide, to be involved in their care when they're taking cannabis. No secrets, okay? They wanted a positive experience. You know, they felt that it was a really positive experience because of the individualization. We told them which product, we guided them through the dose titration, we assessed their symptoms, side effects on an individual patient basis, and they really, really valued that. And then finally, in terms of, you know, there's strong beliefs within that group that cannabis really is a helpful medication for them. That's the last one. They also provided us with input in terms of cost was an issue. And we've talked about that already, the need for insurance companies, and even for that matter, Ontario Drug Benefit and other providers to sort of pay for it. And they also appreciated that there's a lack of evidence, or I would say poor evidence, at least based on our standards, and very much so in terms of wanting to advocate for research. And we actually asked that question. So we asked the question, you know, what's your level of interest in doing research? And 60% of patients were either extremely or very interested in doing research. So there's a desire to use. They want their healthcare team involved in the care of using that cannabis, and they're interested in doing research. Okay, I'm done. Sorry, I was a little bit over time.